Hello and greetings from Kenya. I'd like to speak with you today about COVID-19 in Africa, viewed from the front lines here. Sure, many of you are familiar with the various COVID trackers, and this one's from Johns Hopkins University. And basically you see that much of the world is now covered in big red bubbles, and parts of Africa as well, but at least you can see that Africa has been relatively spared compared to a number of other places in the world. We can compare the metrics between Kenya and the United States. If you normalize Kenya's population to the US population, you can still see that the numbers are far below the US. The positivity rate in both places is pretty high. But the deaths are really much lower. In Kenya, 32 per 1 million compared to 1,200 per 1 million. I'm speaking to you now on the 25th of January, and these statistics were from a week ago. The case fatality rates are different, but not dramatically so. The infection fatality rates, as estimated by a paper published by the WHO, show that it's about 5 times as deadly in the US as it is in Kenya. Now, you do have problems with ascertainment bias, but still this gives you a sense that Kenya may have been relatively spared compared to the US. Both countries really aren't testing enough because the positivity rate is still so high. A group of Kenyan epidemiologists found that by early August of 2020, at least a third of urban Nairobi and Mombasa, the two largest cities in the country, were positive for COVID-19 by serology. And really at the ground level, unlike in the US, Kenyan hospitals were not overwhelmed with this problem. Certainly it was a significant clinical problem. There were some large hospitals in Nairobi that had a couple of hundred COVID patients. But for the most part, in many places around the country, the wards were not full of COVID patients. There were a lot of initial worries for poor outcomes related to COVID in Kenya and the rest of Africa. Kenya is tied for the third largest HIV epidemic in the world with 1.5 million HIV positive Kenyans. There's a lot of childhood malnutrition in the Kibera informal settlement in Nairobi. Nearly half of the kids are stunted. There is limited oxygen capacity and limited ICU capacity. And as much as that's true of Kenya, it's actually much more true of many other African countries in terms of oxygen supply and ICU availability. But as I mentioned, there was already widespread infection in Kenya as early as 6 months ago. So the lower death toll and the lower burdens on hospitals was not due to contained infection. There was something different about the impact of the disease clinically and a difference in the infection fatality rates compared to the West. Those same Kenyan epidemiologists do predict a long tail in Kenya with smoldering cases for some time. Of course, we're still waiting for the vaccine rollout here in Kenya. I worked on the COVID ward at Kijabe Hospital in August and September of last year, and I'd like to share with you about that experience. Some of you may be familiar with this hospital. It is one of the oldest hospitals in Africa and one of the best well-known mission hospitals in terms of being a referral center and a training center and better resource than many other mission hospitals. It has more oxygen capacity, more ICU capacity. Kijabe has an intensive care unit as well as high dependency units on both of the regular wards. It has a pediatric intensive care unit. And as I'll share, it created a COVID intensive care unit. So it has a capacity at the nursing level. It has physician assistants who are trained to deal with ICU level problems. And then it has faculty and attending physicians also capable of working in the ICU. There's a pediatric ward at Kijabe Hospital called Bethany Kids. It's heavily focused in normal times on pediatric surgery. But during COVID, because this wing is somewhat set off from the rest of the hospital, it was converted into the COVID ward, into the isolation ward. And in fact, all patients with any respiratory symptoms at all, even, for example, if the clinician may have thought they had heart failure or a pleural effusion from metastatic cancer, regardless, these patients ended up going to this ward, in part because it became very difficult on those marginal calls to tell whether someone may have COVID or not, and you didn't want to put them on the regular wards. Kijabe has 325 liters per minute of total capacity of oxygen split between 3 different plants. So they have piped wall oxygen. I actually had not worked clinically at Kijabe since I left there in 2006. When I arrived for the first time in 2002, I really didn't realize how fortunate that Kijabe is, and that I was as a clinician, that they had piped wall oxygen and you could give, for example, 15 liters per minute via non-rebreather mask. That is a rare thing in this setting. When I later moved to Malawi in Southern Africa, we had 5 and a couple of 10 liter per minute portable oxygen concentrators, but not the ability to really give consistent, reliable, high flow oxygen from the piping in the wall via a regulator. They have non-rebreather masks, and they have a high flow nasal cannula. So, with a non-rebreather mask, you're usually going to 15 liters per minute. With a high flow nasal cannula, you can start at 25 liters per minute, but you can go as high as 60 liters per minute. And again, that's just something that most hospitals in this setting can't do. So the respiratory wing had an outpatient clinic where any patient who was flagged with respiratory symptoms was deemed at least a COVID suspect and ended up in the respiratory clinic. Some of them had minor problems that could be dealt with as an outpatient, but I'm seen here with a Kenyan clinical officer in the emergency room section of the COVID ward. And so there were a lot of patients there requiring high flow oxygen waiting for admission to the hospital. On the right is the usual pediatric intensive care unit, which had been converted to the COVID ICU. Because of limitations of staff and resources and ventilators, a decision was made that if someone was over the age of 50 or had significant comorbid conditions, they would not be intubated with COVID. And that decision was based on the limited resources combined with the early data that patients on ventilators were not doing well. So during my time on the ward, we only ventilated a couple of patients with COVID. In terms of COVID-19 diagnostics, a PCR was collected locally and then sent to a central lab in Nairobi every day. Later, just recently, in fact, a WHO-approved rapid antigen test has become available. It's really not good enough to, quote unquote, rule out COVID in a high-risk suspect, but can help in patients who are lower risk or asymptomatic, who may be screened prior to surgery. That was a real challenge, was that some patients who needed surgery came in with respiratory symptoms. And again, we didn't think most of those patients had COVID, but it can be high risk putting someone in the operating theater and intubating them. We had pulse oximetry, chest x-ray, and CT. And because the turnaround time on the PCRs was fairly slow, you really had to make a clinical decision. So a patient who came in with what some people call silent or happy hypoxia with a saturation of 50% and bilateral patchopacifications or ground glass opacifications, that was COVID until proven otherwise. For me as an HIV doctor, the condition that I can compare this to the most in our setting is pneumocystis pneumonia. I mean, just in terms of the pulse oximetry and the X-ray picture, it looks similar to pneumocystis pneumonia. Of course, if the patient does not have HIV, or maybe if they have HIV that's well controlled and they're on Bactrim prophylaxis, then that more or less rules out pneumocystis. So the default de facto empirical diagnosis in these patients was COVID-19 until proven otherwise. Here's a typical COVID x-ray. This was a 57-year-old woman who was obese and had diabetes. She actually worked as a community health worker. She had a business, but then worked as a community health worker. And so she was out interacting with people a lot and therefore at high risk for contracting COVID, which she did. Her PCR was positive. She was quite sick for a while, but improved and insisted on leaving the hospital early for financial reasons, said she had to get back to her business. It was costing her too much money to be in the hospital. And, her oxygen saturation was still far from normal. And we tried to convince her to stay, but she left on her own decision. The treatment was more or less protocolized. And my colleague Pete Hallstrup used this mnemonic, A, B, C, D, E, F. Everyone who came in, especially early as there was a surge, we didn't really want it up to everybody's individual judgment about what everyone got. And so they got antibiotics, azithromycin and ceftriaxone. Breathing, of course, was for oxygen. Everyone got oxygen who was admitted to the hospital. We did have dexamethasone, so everyone got that according to the standard protocol of 6 milligrams a day, usually for 10 days. We did also have enoxaparin. My usual clinical work is done at Moa Methodist Hospital, which is a couple hours north of Mount Kenya. And I've taken care of a few COVID patients there, but it's a much poorer hospital and enoxaparin is not always available and often patients can't afford it. So there we would be fortunate to use unfractionated heparin. And then F was for face down or proning. So why was Africa relatively spared? The epidemiologists are still debating this issue, and we might be debating it for some time. But I think the major reasons are probably the age distribution of the population and the comorbidity distribution. Other possible reasons put forward include the outdoor culture here, meaning people aren't hermetically sealed within air-conditioned buildings where there's a super high risk of transmission. However, we saw from that study from Nairobi and Mombasa that in fact, many people had evidence of prior infection already. So it wasn't really that people weren't getting infected, at least in some higher density urban areas, but that they weren't getting as sick or weren't presenting to the hospital as often. There were early mitigation measures, which we believe slowed things down. The airports were closed, the schools were closed, businesses were closed, and that did give the hospitals time to prepare. Others have put forward things like climate. However, again, many people have been infected, as well as it's intriguing to think about pre-existing immunity to other coronaviruses, for example, that may be providing some cross protection against COVID, but that's as yet unproven. Again, if we share here the age structure of the population of Kenya on the right, you can see that only about 10% of the Kenyan population is over the age of 50. And yet America is a much older country. And the infection fatality rate, this was a study from Switzerland, of those over the age of 65, I believe is something like 600 times as much as the infection fatality rate for those under the age of 50. So if you have a lot smaller percentage of your population who are above the age of 65, then it does follow that you're less likely to see severe clinical disease. Also, there's the comorbidity mix. Early on, as I mentioned, we were really worried about people with HIV, also tuberculosis, because so many patients with TB end up with chronic lung disease. And in fact, HIV and TB are risk factors for worse outcome. Data from South Africa suggests the odds ratio is about 2. But we now know that in addition to age, that chronic non-communicable disease comorbidities are really the highest risk, like diabetes, hypertension, chronic kidney disease. And these things are just a lot less common in this setting compared to the West. Now, if you look here at the rates of diabetes in South Africa, you can see that the rate is actually higher than the United States. And South Africa is a little bit older than other African countries. The median age in Kenya's 19. The median age in Malawi is about 17. I think the median age in South Africa is around 27, but that means your tail is a lot longer, meaning you have, in South Africa, you have more people who are older than the age of 65, but that diabetes prevalence also may go some distance toward explaining why South Africa's epidemic has been worse. I'd like to share a few ideas about what lessons we should take so far from, at least from the medical perspective, from COVID-19 in Kenya and the rest of Africa. I think we need to think in terms of systems. Those investments in the ICU at Kijabi, for example, I was part of starting that ICU in 2005. And in fact, we had been doing ICU level care for years before that. And so when COVID hit, they had a lot of physician assistants in a formal training program who knew how to take care of ventilators and very sick patients. So, they were ready for whatever came along, whether it was a car accident or whether it was a severe case of COVID. Of course, the oxygen supply really needs to improve. I'll touch on that, and the importance of higher level care. The oxygen supply in Africa is so limited. As I speak right now, Malawi is really struggling. Their hospitals do have a significant number of COVID-19 patients. There are only a few oxygen plants with piped oxygen in the whole country. Portable oxygen concentrators can be helpful, but in these tropical settings, there's a lot of dust, there's a lot of humidity. It tends to really take its toll on portable oxygen concentrators, which aren't serviced that frequently. And oxygen cylinders are extremely expensive. In Kenya, they can be, for a large cylinder, they might be $55 before transport. In Malawi, I know they're running at least twice that right now. And, a severe patient with COVID can require 3 large oxygen concentrators a day. And that's just not realistic in many of these settings. So there's a real need to improve the oxygen supply, not just for COVID, but I was talking to a hospital in Malawi recently, and they think that about 30% of their surgical mortality is either directly or indirectly due to a limited oxygen supply. So in response to this problem, again, thinking long-term, our organization has launched an oxygen campaign to try to put in a couple of oxygen plants with cylinder distribution at some of our partners in Kenya and Malawi. I mentioned this a cadre of healthcare workers before called an ECHO, an Emergency and Critical Care Clinical Officer. This program was started by Dr. Pete Hallstrup at Kijabi Hospital and others, and it takes clinical officers like physician assistants and upgrades their skills to be able to take care of the ICU and the casualty, to take care of a heart attack or a severe COVID case or a trauma case, severe post-surgical case. And I worked with members of our graduates of this program, and they were just really fantastic. And I came to trust them and rely upon them a lot. And now they're starting to filter out a little bit beyond Kijabi. There's talks about starting other programs. The government is trying to recruit a lot of these graduates. And, it's again thinking what I would call horizontally, not just vertically. So, when thinking about systems, if we look at what happened to ELWA Hospital in Liberia, they were hit by Ebola, and then a lot of organizations came from outside the country and set up hospitals and clinics, but then a lot of people left after Ebola was done. And if you think about setting up long-term longitudinal systems that can deal with a lot of different kinds of problems, whether it's another viral epidemic in the future, or whether it's the rising tide of non-communicable diseases, or it's the chronic care of people with HIV, if you build those systems, and that, what I mean by that, hospitals have to have oxygen, they have to have water, they have to have power, they have to have well-trained staff. They have to have places for those people to live. They have to have a good lab. All these things can be applied to a variety of different problems. And this kind of care in the hospital, ICU level care, can really raise the care across the hospital, because it really shows a level of attention to detail there's an idea in public health called failure to rescue, that if you don't provide care for the sickest patients, then it's actually harder to win the confidence of the community when you want to go out and talk about traditional public health matters. So that's what I wanted to share with you about my experience and what I've seen here on the ground with COVID-19 in Kenya. Thank you for your time.
You know, Paul, Jennifer, every time we hear Dr. Fielder, a flood of information and just great insight into what's going on. Dr. Fielder, thank you for that incredible talk, and thank you for joining us again here live for this Q&A section. Good to see you.
Nice to be back, Chuck. Thanks.
A couple of questions we'll get to, but Dr. Paul, I know you had a couple of
John,
comments.
I love the way, we're all just kind of shaking our heads at why Africa's been spared severe COVID, and I love your explanation or your thoughts on that. But I was wondering about, where I work, much like where you do, especially in the remote areas, there's so much chronic malnutrition, acute malnutrition, chronic anemia, chronic malaria. Are those conditions wouldn't you suspect those would make people more susceptible to COVID, or could it possibly be that especially the chronic malaria or could possibly protect them? Any thoughts on that?
Well, I know, for example, where you work in Zambia, the population is young. So unfortunately, a lot of those kids might be malnourished, but it might be that because they're young, that's relatively protective compared to, being malnourished. Yeah. So I think that age is probably still the driving factor there, although there was just a study that came out of Zambia that found a really high and a discouraging number of people who had died at home, either with or of COVID.
Yeah. Yeah, that's exactly right. We call that brought in dead. Many times they'll be brought into the hospital dead, and we don't really know what they died of. So that's a great point. John, I was going to, having been in Kenya several years, my wife and I, it's amazing to me that a place like Kibera, I think it's almost 1 million people within a square mile or something like that. You have the data better than I do. Isn't it amazing to you that there's just not widespread COVID, severe COVID in a situation like that?
Yeah, I think there is widespread COVID. I think people have really been exposed, and if you tested everyone in an informal settlement like that for antibodies, I think you'd find that they have COVID. Again, as you know, the tradition here is that, as people get older or retire, they move up country and they move to the village. Yeah. So younger people are left in the cities.
Yeah. Seems like age to me is the primary factor there, according to what I heard you say. So that's good.
I think so.
I was going to ask you too about, John, you commented on this beautifully in your talk, but I wish you'd just kind of reiterate the fact that, oxygen therapy is very much needed in hospital settings in Africa. It's very much lacking, especially in mission hospitals. Just talk a little bit about the critical need for oxygen, because I know you and AMH are addressing that to a degree, but just talk about the critical role of oxygen and need for oxygen supplemental systems there.
Well, only about half of the hospitals in Africa have oxygen, and only about 20% of all health facilities. And then when you even look at those that do have oxygen, you're looking at portable oxygen concentrators and maybe a few cylinders. You're not looking at pipe wall oxygen like we're used to in the United States. So you're talking about an enormous resource gap there. I don't have the numbers, but you're going to be talking about hundreds of millions or $1 billion+ worth of oxygen needs to be put into these hospitals.
Yeah, I can tell you we're limited for the most part to just a couple of oxygen concentrators that may or may not work. And certainly out in the remote areas, you can't get the big oxygen tanks. And the optimal thing is a supplemental oxygen system that's generated by the hospital itself. And those are few and far between because they're so expensive. But now we're seeing that some of those can be driven by solar, which is really encouraging.
Yeah, but you still need a pretty big solar system to drive, some of those fixed oxygen plants. So even when you can get the plant, the power costs are significant.
John, any reason you think, your thoughts on why South Africa has been so hit? Do you think it's an age thing there as well?
Well, there was an article by the well-known writer and oncologist Siddhartha Mukherjee last week, and he said, if you look at India, it has the same median age as Mexico and South Africa, and yet India has not been hit as hard as those other two places. So I think age is part of it, comparing South Africa maybe to Kenya and some other African countries, but there's got to be something else.
Yeah.
South Africa has a lot of diabetes. It has a significant obesity epidemic. So I think some of those chronic non-communicable comorbidities are playing a role there.
Good. Thanks.
Yeah, it's interesting you mentioned that. That was one of the questions that was brought up from Margarita, Dr. Fielder. She asked basically, how do you consider that to be an issue? You kind of answered that, and could this be impacting some of that? And then part two was, how do you convince people, specifically in Kenya, to accept the vaccine? There seems to be some hesitancy about that.
Well, I think here so far, I don't know if we've seen hesitancy because the rollout hasn't kicked off yet. The vaccine's just recently come into the country. So we might see that there is some vaccine hesitancy, but I think the bigger challenge is going to be that adult vaccination programs are not something that happens here. Kenya and many African countries do a very good job with pediatric immunizations. Their immunization rates are pretty high, but adults are not used to coming to the hospital for a vaccine. So if you're just waiting at the hospital, I'm worried that actually won't get out to people in the villages. You're gonna have to do community outreach and education.
Yeah, that's good. Before we wrap up our Q&A, what do you think there's a misconception about COVID specifically, and what would you like to say to help educate us and sort of eliminate some of those misconceptions?
Here let me just speak to the Kenyan context. There is some stigma that surrounds COVID, and I don't want to reduce COVID to, well, it's just the flu, but obviously it's a respiratory pathogen like the flu. And so, we don't want to stigmatize, we don't stigmatize people with the flu, so we don't want to stigmatize those people with COVID. So I've had these kinds of discussions with family members when there's some hesitancy about testing or going to the COVID ward. And sometimes it's been a little bit of a challenge.
Yeah. Well, Dr. Fielder, we're thrilled and excited as always to have you as part of the M3 family. We appreciate you joining us again on this quick Q&A. But Dr. Paul, I understand we have a little presentation for Dr. Fielder.
Yeah, John, every year we choose a project of the year, and as you know, we've chosen African Mission Healthcare as our project of the year. So from M3 family, we just donate $10,000 to your ministry. That'll be wired to you very quickly. We believe in you guys, and we appreciate what you're doing, and we stand behind you, and anything we can do to help, we will.
Well, on behalf of African Mission Healthcare and our partner hospitals, and of course the patients they serve, I just want to thank you, Paul, and the M3 Conference and Lakewood Church and everybody who's involved for such a generous gift. Thank you very much.
And we're going to show a short video in just a minute, but I want to remind the viewers that on the exhibitors list, you'll find African Mission Healthcare. And, I would encourage people, that's a great place to give your money. If you want to make a donation, it's a great place that's making a difference, a great organization that's making a difference. So you can find it on our website. Dr.
Fielder, thank you again for joining us today. Dr. Paul just mentioned that video. Let's take a look and see some of the behind the scenes and the work they're doing.
Thanks, John.
My name is Dr. John Fielder. I'm the co-founder and chief executive of African Mission Healthcare. African Mission Healthcare started with the simple idea that no one should go without access to quality medical care. What began 15 years ago is my own crazy dream to create an organization that could come alongside long-term on-the-ground health workers and hospitals has become a reality. Without your partnership, this work would not be possible. 40% of African children who die before the age of 5 do so within the first 28 days of life. 80% of women in rural Uganda lack access to safe C-sections, and 56 million Africans require surgery right now. Africa suffers from 24% of the world's disease burden, but has only 3% of the planet's healthcare workers and only 1% of the resources. We must change this reality. We believe that every child deserves a chance. Every mother deserves to deliver safely, and every person, regardless of where they're born, deserves access to quality, compassionate healthcare. At AMH, we are passionate about bringing healing to the hurting and forgotten. As we celebrate our 10th anniversary, you've helped us make incredible progress. Your support strengthens our mission hospital partners and provides them with equipment, infrastructure, supplies, and training to save lives today and create sustainable health systems for tomorrow. Your partnership pays for medicine and treatment for patients in extreme need and poverty, like Munene, a 16-year-old boy in Kenya who has lived with a bone infection for 10 years. It became so severe and painful that it threatened his limb and his life. Compassionate sponsors through AMH made his surgery possible at one of our partners. Over the last 10 years, with your support, we've enabled 670,000 visits to our healthcare partners and sponsored over 20,000 surgeries and corrective procedures. This year, as the COVID-19 pandemic came to Africa, we saw that past investments in intensive care unit infrastructure and training saved lives now. Dr. Tom and his team care for over 100,000 people at the hospital and at clinics in the surrounding communities and operate on 1,600 patients per year. They have plans to open a training school at the hospital